already that bone mineralization requires two major minerals, the calcium and the phosphorus. And we know that the one which is more likely to be deficient in the preterm babies is phosphorus rather than the calcium. Now, both of them are important and they then get mineralized and deposited. There is an inhibitor of this mineralization named pyrophosphate, which is inhibiting the deposition of calcium phosphate, because otherwise you will have ectopic calcification happening anywhere in the body. And this pyrophosphate, basically, there are multiple proteins and other factors which are regulating its exposure. The osteoblast produces the alkaline phosphatase, which has a degrading effect as far as the pyrophosphate is concerned, and this removes the inhibition of mineralization, allowing the bone formation to happen. So alkaline phosphatase therefore is very important. If you don't have any alkaline phosphatase, you will have no bone mineralization. The bone scaffolding is made, the cartilage is made, the bone is made, but it's not getting mineralized. So what you get is the condition of severe form of hypophosphatasia, in which you will have severe early onset fractures, and you will have hypercalcemia, hyperphosphatemia, because your calcium phosphorus resorption, deposition is not happening, so it's all getting stored out there. This is one of the differentials of metabolic bone disease. What are the features which distinguishes metabolic bone disease from hypophosphatasias other than an alkaline phosphatase level?
Calcium phosphorus levels.
No, in terms of when you see the X-ray, you can say this is more likely to be a.
It will appear hypodense in hypophosphatemia.
Okay.
Whereas any features of rickets.
So they will have more of a rickety changes would be there, and the site of involvement may also be a bit variable in that perspective. So now we know that we form the calcium hydroxyapatite, which is a combination of calcium and phosphorus. The other factors which determine overall the development of the bones include physical activity. So if a baby is not physically active, that could be another factor from that regards. As a corollary, if you do a passive exercise of the baby, somebody does a physiotherapy, that would be able to help you out on that. Many of the earlier preparations of TPM and other factors had a higher content of aluminum. And when we talk about chronic kidney disease associated metabolic bone disease, we know that aluminum inhibits the bone formation. So it's a inhibitor of the bone overall activity, and this could be one of the factors in that regards. Magnesium deficiency plays an important role in the development of metabolic bone disease as well. Now, I'll touch base very briefly. We discussed a lot about how calcium is absorbed and regulated and how phosphorus is absorbed and regulated. A few relevant points from the perspective of the neonatal period. So the calcium we know is regulated via either the transcellular pathway, which basically involves the TRPV6 and is regulated via the calcitriol. And we know that a lot of absorption happens in the newborn period. The other pathway, of course, is the paracellular, which is in between the cells, which is a passive process in that regards. Now, as compared to older individuals who have lesser efficiency of absorption of calcium, neonates have a higher efficiency. So they have around 80% efficiency, which basically means that you don't need that much vitamin D. So particularly in the immediate postnatal period for the next 2 to 3 weeks, even if vitamin D levels are 0, they will be able to absorb a lot of calcium, which basically means that when would the vitamin D deficiency manifest? As hypocalcemia. So it is the late hypocalcemia. So if you have a child who comes to you at 7 days with hypocalcemia, that's not because of maternal vitamin D deficiency. And there are other factors which may interfere the absorption of calcium from that regard. One of a major drug which we discussed about bronchopulmonary dysplasia and other situation where steroids are being used, like chronic lung disease scenario, you would of course be bad for the bones. Glucocorticoid will do everything to decrease the vitamin D level, to decrease calcium absorption, to the calcium formation, to the osteoblast action, to the osteoclast action. So glucocorticoid is something which is bad, of course, for the bone. Drugs like phenytoin, which are not used that often, can also be triggering vitamin D deficiency. So later onset metabolic bone disease may be an abnormality from that perspective. Now, renal calcium handling, we know, does not play a major role in terms of the renal regulation because at the maximum, you can lose 4 milligram per kg per day in the adults. So, which is not a very high dose from that perspective. But why is it important is that if you have too much urinary loss of calcium, you may develop hypercalciuria and nephrocalcinosis. So, which drug predisposes to this scenario, often used in neonates? So long-term furosemide use will behave like a Bartter syndrome-like picture. So hypokalemic alkalosis, hypercalciuria may happen in that regards. Now thiazides basically are going to reduce the excretion of calcium and furosemide and theophylline will increase. So if somebody is on chronic furosemide treatment, you will develop hypercalciuria and nephrocalcinosis will develop from that perspective. And this is the basic scenario from that regards. Now, coming on to phosphorus, we always talked about, and last time we discussed in detail about phosphorus as phosphorus being an orphan sort of a compound, but phosphorus is more important, especially in this age group. So, why do you think that as any other age of life, the neonates are more predisposed to phosphorus deficiency, especially if they are preterm? Anything else? If anybody is having enough food, he will never be deficient in phosphate. Now, the problem in neonates is that they are sick. If they are premature, they may be on parental nutrition. They may not get that. So when we say that the major cause of hypophosphatemia is renal phosphorus wasting, that is true to an extent that if you are eating regularly. But if somebody is on TPN and not getting enough phosphate, then of course they will develop phosphorus deficiency. So this is what makes them unique. And particularly the preterm will be deficient in phosphorus. Now, phosphorus absorption again happens through the two pathways, and we discussed this in detail. Around 80% of human milk phosphorus, that is mother's milk, and 60% of formula is absorbed via the pathway as compared to 80% we talked about the calcium absorption. So it's a good, but if somebody is having formula, you will get less phosphorus from that perspective. Now, this is extremely important. In earlier time when people were using cow's milk or inappropriate formulas who had a wrong calcium phosphorus ratio, there was a risk of developing hypocalcemia. So optimum ratio of calcium to phosphate is somewhere around 1.6 milligram per milligram in that perspective. Now, fetal physiology, we all know that fetus is a parasite and it is able to extract more calcium from the mother than it actually has. So if you talk about calcium versus glucose, what is the difference? Perinatal or fetal glucose metabolism and fetal calcium metabolism, what is the difference? So who has higher blood glucose, mother or child? Who has higher calcium? So that is the major difference. So there is an active gradient which is playing a role in extracting. So fetus is extracting the calcium from the mother even if she is deficient. They are not bothered about that. For glucose, they are actually dependent upon the glucose level. So what are the difference, do you think? How is that physiologically different? Conceptually, it is important. So they are entirely dependent upon how much is your glucose level in the mother. But for calcium, they are not. Even if mother is hypocalcemic, they will suck the calcium out of it, if I use the term in that regard. So what is the difference? So what do they do?
They are not in the future, they are not regulated by.
No, we know that it's entirely dependent. Glucose and calcium, both in fetus are dependent on the mother. But calcium mother is low, fetus is high. There is active transport. For glucose, there is no active transport. So what does it do to ensure that it has enough glucose supply? Let's put it in a very clear fashion. It creates insulin resistance. So this is, in a way, if you look at the various sort of associations of different organisms, you can say this is something like a parasitism sort of a scenario. So they deliberately cause insulin resistance in the mother by the placenta producing the human somatotropin and all the other factors which produce insulin resistance. Here they have got even better mechanism. They have got transporters to transport the calcium, and they've got a very, very important compound which is So PTH related peptide, again placenta. So placental endocrinology becomes relevant from that regards. So now calcium is actively transported from the mother to the baby using the TRPV. Now this is the same. We talked about in kidneys, we talked about in gut, everywhere it's the same, and calcium ATPase. And this transfer ensures a 1.4 to 1 fetal to maternal gradient of calcium. Now, this is largely regulated via the PTH-related peptide, which is acting in a paracrine manner. This is not an endocrine, it's a paracrine effect of PTH-related peptide. So, if you have a condition in like a scenario where you have a type 1 PTH receptor problem like Bloom-Strand disorder, what will happen?
But this PTH related movement of the calcium will not happen after fetal will present with severe.
Yes. So they will have achondrogenesis. That is no chondrodysplasia is because it's not acting directly, but the calcium from the mother is also not coming. So this will be like a double blow in that regards. What about hypoparathyroidism? Why don't you have the same problem in hypoparathyroidism?
So whatever manifestation.
Yes. So it's the PTH receptor which is problem. Now, if you think in a very subtle manner when you talk about PHP, there the PTH receptor ultimately is not working. That is why you have got all that skeletal manifestations of PTH resistance which happen. Now, PTH-RP is also, now it's not just that mother's calcium will be taken, mother will become hypocalcemic, then a parasite doesn't want the host to become totally damaged. It's something else must happen. So what they do is that there is production of calcitriol and PTH in the mother also. Now, what it does is that it causes resorption from the bones. So, if the mother is taking enough calcium and vitamin D, then the bones are fine, but otherwise they will have a risk of bone disease. That is why. So, ultimately, the ionic calcium in the mother is also not low. Now, fetal parathyroid may not play a very important role in the antenatal period, but it is active. So, if the mother is hypocalcemic, baby is hypocalcemic, PTH becomes high. What will happen after birth in such a scenario? Yes. So as you talked about, infant of diabetic mother, mother sugar is high, baby's sugar is low. If you talk about a scenario of hypoparathyroidism or hypocalcemia, baby will present with hypercalcemia. So this PTH is actually not getting regulated in a way, but it is automatically getting regulated in the fetus in that regards. Now, magnesium acting via the calcium sensing receptor will basically suppress this whole activity. So, if a mother is being given multiple doses of magnesium in the setting of eclampsia or in the setting of prematurity, that may cause problems in terms of fetus subsequently. So, this is something you have to worry about. So, magnesium may not be good for the bone as well. Now, we have discussed already that most of it happens in the third trimester. So, calcium accrual, typically if you see by 10 weeks, there's hardly any calcium. Then from there, the rate is typically rising to 50 only at 25 weeks. And after that, there is a sudden rise going up to around 120 milligram per kg per day. So, the baby is getting good infusion of 120 milligram per kg per day of calcium, which is a huge amount in that regards. And phosphorus also mirrors the same thing. It's a later rise, the lesser amount. So again, typically the ratio of 1:2 that we talk about. And this gives you an idea as to how much should be your prophylactic dose to the baby to prevent metabolic bone disease. So of course, if you're giving IV, you will need less. When you're giving in an oral preparation, you need a more higher doses from that regard. So this is the critical period of around the last trimester in which it becomes relevant in that regards. Now, birth, of course, is a watershed event. As soon as the birth happens, the baby's exposure to cold, to hypoglycemia, to hypocalcemia, to every other thing starts happening, and suddenly all the supply goes on. So now whatever they have stored in the bones will be used. If you remember, for hypoglycemia, we say the liver has got glycogen and it will produce enough glycogen to ensure, but it will come down very rapidly from that perspective. So as soon as birth happens, the PTH level will go up, calcitonin level will go down, and calcitriol will go up. The major player here is actually PTH. And this PTH, where will it get the calcium from, Vibha? Where will the calcium come from? Bones. So if you are not having enough store, your bones are going to become weak. And everybody who is born will lose bone. If your bank balance is less, your bones will become weak. That's a simple concept basically. So you expect that they are storing these bones. So in a way, bones are the storage part for the calcium supply.